Welcome to Unit 3, where we'll begin our discussion on cardiovascular and peripheral vascular disorders. In this unit, we'll focus on how the heart and blood vessels work together to maintain perfusion, and how conditions such as hypertension, coronary artery disease, venous disorders, and peripheral arterial disease disrupt that balance. We'll also briefly introduce cardiac rhythm strips to support dysrhythmia recognition, with a more detailed review coming in Unit 4. As we move through the material, pay close attention to how changes in heart rate, blood pressure, vessel function, and blood flow affect patient symptoms and nursing priorities. Let's get started.
This slide introduces the core concepts of cardiac structure, function, and tissue perfusion, which everything else in this unit builds on. Let's start with cardiac output. Cardiac output is calculated as heart rate multiplied by stroke volume. Both components matter. Even if stroke volume is normal, a slow heart rate, or bradycardia, reduces cardiac output by decreasing the number of times the heart pumps each minute. When cardiac output falls, tissue perfusion decreases, meaning organs receive less oxygenated blood. This effect is especially significant in clients with heart disease, because their ability to compensate is often limited. As a result, bradycardia can lead to symptoms such as hypotension, dizziness, fatigue, and poor organ perfusion. Adequate tissue perfusion depends on three essential elements working together: an effective cardiac pump, enough circulating blood volume, and patent responsive blood vessels. If any one of these components fails, perfusion becomes impaired. The third section of this slide reviews the cardiac electrical conduction pathway. The electrical impulse begins in the sinoatrial, or SA, node, then travels to the atrioventricular, or AV, node, where a brief delay allows the ventricles time to fill. The signal then moves through the bundle of His and Purkinje fibers, triggering coordinated ventricular contraction. This precise sequence ensures efficient pumping and optimal cardiac output. Disruptions in rate, rhythm, or conduction directly affect perfusion and can quickly lead to clinical deterioration. This slide sets the foundation for understanding why changes in heart rate, rhythm, or structure have immediate effects on patient stability.
Let's move on. This slide builds on cardiac structure and function, focusing on ventricular performance. Let's start with the S3 heart sound. An S3 occurs early in diastole, just after S2, and is associated with rapid ventricular filling. In adults, hearing an S3 is most often linked to volume overload and reduced ventricular compliance, and it is commonly heard in heart failure. An S3 indicates that the ventricle is struggling to handle the incoming blood volume efficiently. This abnormal filling pattern signals worsening pump function and helps explain symptoms such as fatigue and shortness of breath. The second part of this slide focuses on ejection fraction, or EF, which helps quantify how well the left ventricle is pumping. A normal ejection fraction is approximately 55 to 70%. When ejection fraction is reduced, it reflects systolic dysfunction, meaning the ventricle cannot eject blood effectively with each contraction. This decrease in forward flow leads to reduced cardiac output, which contributes to fatigue, dyspnea, and exercise intolerance. Together, the presence of an S3 and a decreased ejection fraction provide important clues about ventricular dysfunction and help guide further evaluation and management. These findings reinforce how changes in structure and function directly affect tissue perfusion.
Let's move on. This slide introduces coronary artery disease and acute coronary syndromes, which occur when blood flow to the myocardium becomes inadequate. On the left, we're reviewing the progression of ischemia, injury, and infarction. Cardiac tissue damage begins with ischemia, meaning reduced blood flow and oxygen delivery to the heart muscle. If ischemia persists, it progresses to injury, where myocardial cells are stressed and damaged but may still be viable. Without timely intervention, prolonged injury leads to infarction, which is irreversible tissue death. This sequence forms the basis of acute coronary syndromes and explains why early recognition and treatment are so critical. On the right, we focus on angina, one of the most common manifestations of coronary artery disease. angina typically presents as exertional chest pain that is relieved by rest. This pain occurs because physical activity increases myocardial oxygen demand, but fixed coronary artery narrowing prevents blood flow from increasing enough to meet that demand. When the patient rests, oxygen demand decreases and the pain resolves. It's also important to distinguish cardiac from non-cardiac chest pain. Non-cardiac chest pain often worsens with movement, coughing, or deep breathing, which helps guide clinical assessment. This slide reinforces how understanding the pathophysiology of ischemia and angina supports rapid assessment, appropriate intervention, and improved patient outcomes.
Next, we'll focus on cardiac biomarkers and medication effects. On the left, we're reviewing troponin I, which is a cardiac-specific biomarker released into the bloodstream when myocardial cells are injured. Because troponin I is found only in cardiac muscle, an elevated troponin level confirms myocardial injury, including myocardial infarction. Troponin levels begin to rise within hours of injury and may remain elevated for several days. Even an early elevation is clinically significant and reflects damage to the myocardium, which directly reduces contractility and overall heart function. On the right, we focus on nitroglycerin and its therapeutic effects. Nitroglycerin works by causing systemic vasodilation, which reduces preload and lowers myocardial oxygen demand. This helps relieve ischemic chest pain by decreasing the workload on the heart. Because vasodilation is systemic, patients commonly experience headache, dizziness, and hypotension. These effects are expected and should be included in patient education so they are not mistaken for worsening cardiac symptoms. Understanding how troponin confirms myocardial injury and how nitroglycerin improves oxygen balance helps nurses interpret lab results, monitor for adverse effects, and support safe, effective management of acute coronary syndromes.
Let's move on. This slide focuses on prevention strategies and post-myocardial infarction teaching, which are essential for reducing future cardiac events and supporting long-term recovery. We'll start with primary prevention, which applies to clients who may have risk factors but have not yet had a cardiac event. Primary prevention priorities include smoking cessation, dietary management, and blood pressure control. Addressing these modifiable risk factors early helps slow the progression of coronary artery disease and reduce the likelihood of myocardial infarction. Secondary prevention applies after a cardiac event has occurred. The focus shifts to symptom recognition, medication adherence, and continued lifestyle modifications to prevent further damage. Teaching patients to recognize early warning signs and take medications consistently plays a key role in preventing recurrent events. After a myocardial infarction, discharge teaching should reinforce several important points. Patients need to understand the importance of medication adherence, engaging in gradual and supervised physical activity, maintaining a heart-healthy diet, and monitoring for warning symptoms such as chest pain, shortness of breath, or unusual fatigue. Nurses should encourage patients to seek prompt medical care if symptoms recur, rather than waiting or attempting to manage symptoms at home. Early intervention can limit additional myocardial damage. Overall, this slide reinforces how prevention and patient education directly affect survival, recovery, and quality of life following myocardial infarction.
Let's move on. This slide focuses on venous disorders, including venous thromboembolism risk, deep vein thrombosis, chronic venous insufficiency, and varicose vein prevention. We'll start with VTE risk factors. The risk for venous thromboembolism increases with estrogen use, such as oral contraceptives, as well as surgery and immobility. These factors promote venous stasis and increased clot formation, which is why close monitoring and early prevention strategies are essential in at-risk patients. The next section addresses suspected deep vein thrombosis. Classic signs include unilateral leg pain, warmth, swelling, and redness. When DVT is suspected, the priority nursing action is not to massage the affected limb, as this can dislodge the clot. The nurse should notify the healthcare provider immediately to prevent clot migration and possible pulmonary embolism. Moving to chronic venous insufficiency, this condition occurs when venous valves are damaged or ineffective, leading to blood pooling in the lower extremities. Management focuses on improving venous return. Compression stockings should be applied in the morning before swelling develops and removed at night. Patients should also be encouraged to walk regularly and avoid prolonged standing. The final section focuses on varicose vein prevention. Regular walking activates the calf muscle pump, which improves circulation and reduces venous pressure. Compression stockings provide additional support to vein function and help reduce swelling. Avoiding prolonged standing or sitting helps prevent blood pooling in the leg veins. Overall, this slide reinforces that early recognition, prevention, and patient education are key nursing strategies for managing venous disorders and reducing complications.
Let's move on. This slide focuses on peripheral arterial disease, or PAD, which results from reduced arterial blood flow to the extremities, most commonly the legs. A hallmark symptom of PAD is intermittent claudication. This presents as exertional leg pain, often described as cramping or aching, that occurs with walking or activity and is relieved by rest. The pain happens because narrowed arteries cannot deliver enough oxygen to meet muscle demand during activity. Once the patient rests, oxygen demand decreases and the pain resolves. This pain pattern is important to recognize because it helps distinguish PAD from venous disorders, where discomfort often improves with elevation rather than rest. The slide also mentions Raynaud's phenomenon, which involves vasospasm of small arteries, usually in the fingers or toes. Vasospasm limits blood flow and leads to impaired tissue perfusion, causing color changes, pain, and sensitivity to cold or stress. Early recognition of PAD symptoms is critical. If left untreated, reduced blood flow can progress to tissue damage, non-healing wounds, or ischemia. Management of PAD focuses on improving blood flow and reducing risk factors, such as smoking cessation, blood pressure control, and activity modification. Nursing care plays a key role in symptom recognition, patient education, and preventing complications related to impaired perfusion.
Let's move on. This slide focuses on atrial fibrillation, or AFib, which is a common cardiac dysrhythmia with significant implications for cardiac output and stroke risk. We'll start with the management goals. In atrial fibrillation, the atria do not contract effectively, which leads to blood pooling and increases the risk for thrombus formation. At the same time, a rapid ventricular response can reduce ventricular filling time and lower cardiac output. Because of this, management focuses on two main goals: rate control to maintain adequate cardiac output and stroke prevention to reduce the risk of embolic events. The medication section highlights diltiazem, which is commonly used to slow AV node conduction and control the ventricular rate. Slowing the heart rate allows more time for ventricular filling and improves perfusion. To address stroke risk, anticoagulation therapy is used. Heparin may be started initially, and longer-term anticoagulation is often managed with warfarin or other agents to prevent clot formation. The final section focuses on monitoring anticoagulation. Warfarin therapy requires INR monitoring, with a typical target range of 2 to 3 for atrial fibrillation. Heparin therapy is monitored using PTT. It's also important to consider renal function, as renal insufficiency can increase bleeding risk and may require dose adjustments and closer monitoring. This slide reinforces how managing atrial fibrillation requires balancing rate control with anticoagulation to protect both cardiac function and neurologic outcomes.
Let's move on. This slide focuses on heart failure markers and medication-related risks, which are important for both diagnosis and ongoing management. We'll start with BNP, or brain natriuretic peptide. BNP is released when the ventricular walls stretch, which commonly occurs with volume overload in heart failure. An elevated BNP level supports a diagnosis of heart failure and is especially helpful when patients present with symptoms like shortness of breath or fatigue. BNP also helps differentiate cardiac causes of dyspnea from non-cardiac causes, such as pulmonary conditions. In addition, trending BNP levels over time can help evaluate response to treatment, as decreasing levels often reflect improving ventricular function and reduced volume overload. The second part of this slide addresses furosemide, or Lasix, and related nursing considerations. Furosemide is a loop diuretic used to reduce fluid overload, but it can also cause dehydration due to increased urine output. Hypokalemia is a common side effect and requires close electrolyte monitoring, as low potassium levels increase the risk for cardiac dysrhythmias. Furosemide can also cause orthostatic hypotension, which increases fall risk, particularly in older adults. Nurses should monitor vital signs, encourage slow position changes, and educate patients to report dizziness or lightheadedness. Overall, this slide reinforces how laboratory markers and medication effects work together to guide safe and effective heart failure management.
Let's move on. This slide focuses on orthostatic hypotension and lipid profiles, both of which have important implications for patient safety and long-term cardiovascular health. We'll start with orthostatic hypotension, which occurs when blood pressure drops significantly upon standing. This sudden drop can cause dizziness, lightheadedness, or fainting due to reduced cerebral perfusion. Orthostatic hypotension is a major fall risk, especially in older adults and in patients with cardiovascular disease, or those taking medications such as diuretics or vasodilators. Because of this risk, careful monitoring is needed when patients move from lying to sitting and from sitting to standing. Nursing interventions focus on slow position changes, ensuring adequate hydration, and reinforcing safety measures to reduce the risk of falls. Falls related to orthostatic hypotension can lead to serious injuries, making prevention a key priority. The second part of the slide reviews lipid profiles, specifically LDL and HDL cholesterol. LDL, or low-density lipoprotein, is considered bad cholesterol because it contributes to plaque buildup in the arteries. Elevated LDL levels promote atherosclerosis, increasing the risk of coronary artery disease and stroke. HDL, or high-density lipoprotein, is considered good cholesterol. It helps remove LDL from the bloodstream, providing a protective effect against arterial blockages. Higher HDL levels are associated with lower cardiovascular risk. Effective cardiovascular risk management aims to lower LDL and raise HDL through lifestyle changes and, when needed, medication therapy. This slide reinforces how both short-term safety concerns, like fall risk, and long-term risk reduction, like lipid management, are central to cardiovascular nursing care.
Now, let's briefly review what a cardiac rhythm strip is. In Unit 4 next week, we'll revisit rhythm strips in more detail, but this overview will help build a foundation for understanding diagnosis, treatment decisions, and patient safety. Cardiac rhythm strips give us visual information about heart rate, rhythm, and electrical conduction. This helps us understand how effectively the heart is beating and whether blood flow and perfusion are being maintained. Interpreting rhythm strips isn't just about naming the rhythm. It guides clinical decisions, such as when to control heart rate, when anticoagulation is needed, or when a rhythm requires urgent intervention. When you analyze a rhythm strip, focus on a few key areas rather than trying to memorize patterns. Start by identifying the heart rate, then determine whether the rhythm is regular or irregular. Next, look for P waves to assess atrial activity and evaluate the QRS width, which tells us whether conduction through the ventricles is normal or abnormal. Heart rate tells us how fast the heart is beating, while rhythm regularity shows whether the beats occur at consistent intervals. Together, these findings help determine how well the heart is functioning. Understanding these fundamentals will make it much easier to recognize abnormal rhythms, especially atrial fibrillation, which we'll discuss next.
Let's move on. This slide reviews sinus rhythms, including normal sinus rhythm and its common variations. Sinus rhythms are important because they represent the heart's baseline electrical activity. All sinus rhythms originate from the SA node, which is the heart's natural pacemaker. Because of this, sinus rhythms generally maintain organized conduction, but variations in rate can still have important clinical effects. We'll start with normal sinus rhythm, or NSR. In NSR, the heart rate is between 60 and 100 beats per minute, the rhythm is regular, and there is a P wave before every QRS complex. This tells us that the electrical impulse is originating from the sinoatrial, or SA, node, and conduction through the heart is normal. Next is sinus bradycardia, which occurs when the heart rate falls below 60 beats per minute. A slower heart rate can reduce cardiac output, especially in patients who cannot compensate. Depending on the situation, patients may experience dizziness, fatigue, or lightheadedness, particularly if perfusion is affected. Sinus tachycardia is defined as a heart rate greater than 100 beats per minute. This rhythm increases myocardial oxygen demand and can place additional stress on the heart. It is often seen during exercise, illness, pain, anxiety, fever, or hypovolemia, and may be a sign that the body is responding to stress. The key takeaway from this slide is that while sinus rhythms are organized, changes in heart rate alone can significantly affect perfusion and patient symptoms, making careful assessment essential.
Now we're going to focus on atrial dysrhythmias, specifically atrial fibrillation and atrial flutter, which are both common and clinically significant rhythms. Let's start with atrial fibrillation, or AFib. AFib is characterized by an irregular rhythm and the absence of distinct P waves. Instead of organized atrial contraction, the atria are quivering. Because the atria are not contracting effectively, blood can pool in the atria, which significantly increases the risk for clot formation and stroke. This stroke risk is one of the most important concerns associated with AFib. Next is atrial flutter. A flutter is identified by characteristic sawtooth flutter waves on the rhythm strip and often has a more regular ventricular response than AFib. Even though atrial flutter looks more organized, it still originates in the atria and results in ineffective atrial contraction, which means it also carries an embolic and stroke risk, similar to AFib. When we compare AFib and aflutter, the key similarity is that both originate in the atria and increase embolic risk. The underlying problem in both rhythms is poor atrial contraction, which promotes clot formation and can lead to stroke. Accurate rhythm identification is critical because it guides decisions about rate control, anticoagulation, and long-term management. The key takeaway from this slide is that while AFib and aflutter look different on the rhythm strip, both require careful monitoring and stroke prevention strategies.
Let's move on. This slide provides an overview of heart blocks, which occur when electrical conduction between the atria and ventricles is delayed or completely interrupted. We'll start with first-degree AV block. In this rhythm, there is a prolonged PR interval, meaning conduction through the AV node is slowed. However, it's important to note that every atrial impulse still reaches the ventricles. Because conduction is delayed but intact, first-degree AV block is often asymptomatic and may not require immediate intervention, though it should be monitored. In contrast, third-degree, or complete, AV block is much more serious. In this condition, there is no relationship between P waves and QRS complexes, meaning atrial impulses do not conduct to the ventricles at all. As a result, the ventricles generate their own escape rhythm, which is typically very slow. This leads to severe bradycardia, reduced cardiac output, and a high risk for hemodynamic instability, including hypotension, syncope, and altered mental status. Third-degree AV block requires urgent clinical attention and often pacing. Overall, AV blocks disrupt the normal coordination between atrial and ventricular contraction. When this coordination is lost, the heart cannot pump efficiently, which can lead to significant cardiac complications. The key takeaway from this slide is recognizing which blocks are benign and monitored, like first-degree AV block, versus those that are emergent, like third-degree AV block.
Next, this slide focuses on ventricular dysrhythmias, which are immediately life-threatening conditions and require rapid recognition and action. We'll start with ventricular tachycardia, or VTAC. VTAC is characterized by a wide QRS complex and a rapid ventricular rate. Because the ventricles are beating too fast to fill properly, cardiac output drops, and the rhythm can quickly progress to cardiac arrest if not treated. VTAC is always a serious rhythm. Depending on whether the patient has a pulse and is stable, Management may involve medications, synchronized cardioversion, or advanced cardiac life support. Immediate medical intervention is required. Next is ventricular fibrillation, or VFib. VFib presents as a chaotic, disorganized rhythm with no identifiable QRS complexes. There is no effective ventricular contraction, which means no cardiac output and no perfusion. Ventricular fibrillation is a medical emergency and requires immediate defibrillation and CPR. Without rapid treatment, VFib is fatal. The final section of this slide emphasizes critical recognition for survival. Early detection and prompt response are essential. Recognizing these rhythms quickly allows for immediate intervention, which can restore effective heart rhythm and save lives. The key takeaway is that ventricular dysrhythmias are never benign. Rapid identification and urgent action are critical nursing responsibilities.
To wrap up, this final slide offers brief practice with common dosage calculations. Work through each question independently to strengthen both accuracy and confidence in medication math. Thank you all for your attention and engagement throughout Unit 3. In this unit, we focused on cardiovascular and peripheral vascular disorders, building on earlier concepts of perfusion and cardiac function. We also introduced cardiac rhythm strips as a foundation, and in Unit 4 next week, we'll revisit rhythm strips in more detail to deepen your understanding of diagnosis, treatment decisions, and patient safety. Continue practicing how to apply this information to clinical scenarios, especially when prioritizing patient safety and recognizing early signs of deterioration. As always, if you have any questions, feel free to reach out. Thank you again, and I'll see you in the next session.